morning. My name is Tashandra Thomas, and I will be introducing Dr. Dolin. Dr. Dolin serves as the Vice Chair of the HL7 Board of Directors and has been involved with the organization since 1996. Dr. Dolin is an internationally renowned and innovative physician, expert in healthcare information technology standards development, with more than 20 years of clinical experience. After receiving his medical degree, he served as chief resident at UCLA Department of Medicine in 1989, where he developed Harbor UCLA's first outpatient electronic medical record system. Dr. Dolin is a fellow in the American College of Physicians and was elected into fellowship in the American College of Medical Informatics in recognition of his work in standards development. Dr. Dolin is president and chief medical officer of Lantana Consulting Group, a healthcare consulting firm offering services and software for standards-based health information exchange. Dr. Dolin also co-chairs the HL7 Structured Documents Work Group and is co-editor of HL7 Clinical Document Architecture and Specifications. He has also served on the SNOMED CT Content Committee and currently co-chairs the U.S. HIMSS Foundation Committee. Dr. Dolin's work has also been published in both technical and clinical peer-reviewed journals. Thank you.
Good afternoon, everyone. I guess before I get started, I want to say that I am left inspired and I am reminded why I'm here after listening to Dr. Simpson and Dr. Farney's presentation. When I hear the real concrete use cases that really speak to the need for clinical data, it kind of makes me feel like, good, maybe I'm, behind the scenes doing something valuable to support these really critical clinical initiatives. What I've been working on in the last, 15, 20 years is, turn that on. Did you hear my accolades, Dr. Simpson and Dr. Farney? Okay. Overdue. So to me, it's because there are these innovative uses of clinical data. For me, it's been about the data. It's about helping to convert healthcare into a data-driven industry the way we would like it to be. Through the federal initiatives called Meaningful Use, and I presume most people are familiar with Meaningful Use. Is there anyone that's not familiar with Meaningful Use? Or that is not embarrassed to raise your hand? Okay. So what I want to talk about today is not specifically how meaningful use is getting the data flowing, but how we are trying to shape meaningful use and meaningful use in the future towards an approach that I refer to as big data, incrementally structured. How we're anticipating getting large volumes, how we're trying to get an exponentially greater volume of data flowing to support the key initiatives and the data-driven applications that Dr. Simpson and Dr. Farney described. So I call this an alternate view to meaningful use. Another way that you could label this would be the big data incrementally structured approach. So I guess maybe this is, where we are today or maybe where we were in the past. But here's where we're trying to go with meaningful use, which is to take all of this information and figure out a way to leverage it to improve patient care, trying to convert healthcare into a data-driven industry the way that we believe that it should be. Did you ever read the book, The Phantom Tollbooth? Oh, it's a great story. And I bring this slide in here. Probably this slide is not so necessary for this audience, but I didn't know that this audience would be this sophisticated, so I threw this slide in here anyhow. Plus, if you've ever read the story, it's a great story about a boy named Milo, this lost little boy who's traveling in search of rhyme and reason. And one day he comes home and he finds a toll booth and a little car in his room, and he goes off in search of rhyme and reason. And one day he's traveling through this town called Dixonopolis. And in Dixonopolis, there are these wizards. There's these 5 wizards. And anytime one of the wizards says something, each of the other wizards has to repeat it, but they have to say it in a different way. And Milo, junior informaticist that he is, says, well, why don't you guys each say it the same way? Wouldn't that make more sense? And I think that this is a nice illustration of what we're trying to do with interoperability standards. And you can imagine, for instance, if you have a decision support rule and you're receiving data from a number of different settings and you want your decision support rules to continue to trigger and fire reliably with high sensitivity and high specificity, the more we can get consistency in the data, the more we can understand the different types of data that are flowing, the more we can really start to enable a data-driven healthcare. I think it was Dr. Simpson that said, if you can't measure it, you can't improve it. And this is what Lord Kelvin said. And I like to believe that standards, interoperability standards, are a prerequisite to functionality. So when we look at what we're trying to do with sepsis, when we look at what we're trying to do with advancement in pharmacogenomics, I believe that what we really want to do is to begin standardizing the data. So Lord Kelvin said, if you can't measure it, you can't improve it. I would add, if you can't standardize it, you can't measure it. And if you're still not convinced, there you go. So now we all believe standards allow us to measure care, and that allows us to improve care. So before I kind of talk about the alternate view to meaningful use, or what I might call the big data incrementally structured strategy that we're moving towards in meaningful use, I want to just kind of do a little bit of an overview, maybe the 50,000-foot view of where I see meaningful use today. On the left, what you see is a meaningful use certified EHR. Because it's a meaningful use certified EHR, it has adopted certain interoperability standards. And because it has adopted those interoperability standards, there are certain capabilities of that EHR that we can rely on for decision support, for quality reporting. So for instance, this meaningful use certified EHR can speak in terms of standardized problems. It can speak in terms of standardized medications. When we now write our quality reporting criteria, and when we now, in meaningful use stage 3, start to write our decision support rules, if we write the quality reporting criteria based on the same standards that this EHR can speak, given the fact that it's a meaningful use certified EHR, it stands to reason that this EHR can automatically consume this quality report and generate the results. It stands to reason that we can create shareable decision support rules that can be consumed by an EHR to actually intervene in the process of care and help drive towards those types of interventions that we believe improve care. So our goal with meaningful use is to think about the whole spectrum of care, not just in terms of what standards go from a lab system to an EHR, and not just what standards allow a patient to move from their primary care provider to their cardiologist, but think about the big picture view, and those interoperability standards that are being used to support transitions of care are the same interoperability standards that we then leverage when we create clinical quality measures and decision support rules so that they can then be consumed by those same systems. This is a graphical representation. It's a little bit simplified, but it's a graphical representation of the way that quality reporting works under meaningful use stage 2. In meaningful use stage 2, now the way that meaningful use works, and probably a lot of you are probably intimately, maybe painfully aware of the way that meaningful use stage 2 works, but meaningful use defines a set of criteria. And an EHR system has to demonstrate that it can satisfy those criteria in order for it to then become a certified EHR. For quality reporting, an EHR has to demonstrate its ability to capture data elements required for certain quality reports. The EHR has to demonstrate its ability to generate quality reports, individual patient-level quality reports. So for instance, if we're looking at the acute MI measure, and we say that there's, you should give aspirin within this amount of time for a patient presenting to the emergency room with a heart attack, we can, for each of those patients, we can generate an individual quality report, and these quality reports have to be able to be generated in a standardized format, and the standard is cited under meaningful use. Then there has to be the capability to consume those quality reports into a calculation engine, and from there spit out the aggregate quality report. So here, for instance, this would say, okay, for the acute MI measure, I have 27 patients that met the denominator criteria, of which 20 patients met the numerator criteria. So the way that quality reporting works under meaningful use is the EHR has to demonstrate its ability to capture the data elements that are necessary depending on the particular quality measures that they have signed up to implement. The EHR has to be able to generate quality reports that contain those data elements, and they have to be able to spit these out in a standardized format. They have to demonstrate the ability to consume those quality reports and run them through a calculation engine and generate the aggregate score. Okay? I think that talking about sepsis and talking about pharmacy is a little bit more tangible. I think here what we're trying to drive to is what kind of steps do we want to take to make sure that the data is flowing that's going to support sepsis, that's going to support, well, maybe the improvement in sepsis outcomes, or that's going to improve our ability to safely monitor medication use. Under meaningful use stage 2, has anybody never heard of HL7 before? Okay, so a lot of people still embarrassed to raise their hands. So under meaningful use, so meaningful use stage 2 cites those interoperability standards. Primarily the place where the interoperability standards are created is an organization called Health Level 7, an international standards development organization. Some of the key standards include the HL7 clinical document architecture and various HL7 clinical document architecture implementation guides. Now, I'm not trying to teach you all of the HL7 acronyms, and I'm not trying to teach you about all of the specific standards, but when I start introducing these particular standards, you're going to see that the basic principles by which these standards are developed are going to be leveraged under meaningful use stage 3 to support this notion of a big data, incrementally structured approach. So while it's not critical for today that you understand the guts of the CDA standard, you'll see that we're going to talk about the CDA standard in a little bit more detail with respect to how it kind of gets large volumes of data flowing in healthcare. So under meaningful use stage 2, we have reference to the HL7 Consolidated CDA Implementation Guide, which is a standardized representation of all of those notes that Dr. Simpson said, boy, if I could harvest the clinical documents, how would that improve my ability to detect sepsis? So we have the consult note, the H&P, the progress note, et cetera. And under meaningful use stage 2, we have other CDA-based implementation guides for quality reporting. So a lot of CDA-based implementation guides are being used. In meaningful use stage 1, there was one CDA implementation guide that was referenced. In meaningful use stage 2, there's 11 CDA-based implementation guides that were referenced. So the question is, what's driving the dramatic increase in the number of CDA-based implementation guides under meaningful use? So without trying to make you experts in CDA, I mean, if you want to become experts in CDA, that's okay too. But without trying to make you experts in CDA, what I want to try to describe is why is it so popular? Then we'll shift focus and we'll start talking about big data and how CDA and how the work we've been doing in HL7 really is trying to enable us to drive towards a data-driven healthcare environment. And what I find to be probably the most like, gosh, I really need to noodle on that one, question is, let's say that you know that you need, I don't know, 150 data elements, okay? We know that we need 150 data elements. What's the best way to get those 150 data elements? Well, there's a couple of ways you could go at it. You could go at it the direct way, or you could go at it the indirect way. Going at it the direct way, for instance, the provider who's, I think you mentioned 40%, they're spending 40% longer in clinic today, partly because of all of the requirements under meaningful use. You did your documentation, but darn, now there's this structured data entry form that I have to interact with. There's these 17 other fields that I have to fill in. So we can go after the 100 data elements that we believe are important by going after them directly, or we can go after them indirectly by leveraging existing clinical workflow, by meeting the needs of frontline clinicians on day one, and by incrementally adding more structure to data that's readily available today and can easily be converted into a format that can be communicated today. So the strategy we're taking with this standard, and I believe one of the reasons that it's become so popular, is it allows us with very little work to get humongous volumes of data flowing in healthcare and provides a glide path that allows us to incrementally add structure. So that while today people look at narrative text and they say, well, why would I want to spend my time moving narrative text in the US if what I really want are these 100 pieces of discrete data? The answer is because it's the best way to get you there. We have, HIMSS estimates that we have roughly 1.2 billion clinical documents produced in the United States per year, and HIMSS has estimated that clinical documents account for roughly 60% of the information content in the EHR. It turns out that it's not too hard to take these documents and convert them into a minimally conformant CDA-based format. CDA is an XML standard that standardizes the representation of clinical documents. It turns out that it's pretty easy to take these narrative documents and convert them into a minimally conformant CDA structure. We've been working very closely in HL7 with one of the HIMSS groups called the Health Story Consortium. The Health Story Consortium is comprised of a number of members, including a number of transcription vendors. And the transcription vendors normally spit out either Word documents but it turns out that it's not that much more difficult for them to spit out CDA documents. The CDA documents that are produced, what's interesting about these CDA documents is that they meet the needs of the frontline clinicians from the get-go. So in this particular strategy where we focus on getting the data flowing and then incrementally adding structure to it, one of the offshoots of that is that for very little work, for very little energy, not only do we have massive amounts of data flowing, and that can drive big data analytic engines, but also we have good old-fashioned clinical documents flowing, and that supports the needs of frontline clinicians because it's going to take us a while until we get to the 200 data elements that we need. And even when we get to the 200 data elements that we might need to trigger a decision support rule, I would propose that that's not necessarily going to meet the needs of the internist working in the emergency room seeing a sick patient for the first time. They're going to want to see a recent discharge summary. They're going to want to see a recent consult note. So our strategy here with CDA is get the data flowing and incrementally add structure where valuable to do so, and approach the problem of data interoperability in a piecemeal, in an incremental fashion in the United States. So I'm going to say that 5 more times before I sit down, okay? So I sometimes like to refer to this approach as the big data incrementally structured approach. And you probably recognize this slide. Most people will think of Robert Frost's poem about 2 roads that diverged. And right now, we're still on the road that's slightly less traveled. And the reason I say this is because we all want discrete data. We all believe that we need discrete data to drive decision support. We need discrete data to drive quality reporting. But we believe that there are different strategies that can be taken to get us there, to get us to discrete data. We can go after the discrete data directly, or we can kind of approach going after discrete data indirectly. And that's where I think probably there's a real fundamental shift in mindset that's taking place right now, inspired by Google, inspired by the internet, inspired by the big data drive, which is if we want to get there, we don't necessarily have to say to clinicians, okay, you just finished documenting the stuff that you would normally document. Now, by the way, you got to go to this other data entry field and capture these other 17 variables. You can kind of sort of keep pursuing your normal clinical workflow based on clinical documents, and incrementally we can add more data elements in there where there's what I call a clinical return on investment to do so. Big data, incrementally structured. So here's what we're up against in healthcare is that clinicians, they don't want to spend 40% more time in the office. Some of them want to go home at some point, and yet what's happening, or what's at risk of happening with the introduction of electronic health records and with the introduction of quality reporting and decision support, is this growing need for structured data elements. And so on the one hand, clinicians want a fast way of documenting. I mean, people say that the data that they're looking for is the data that comes directly from the clinician. They want to get data as close to the source as possible. And yet, at the enterprise level and at the federal government's level, they want structured data because that's how they know what's going on in the country. That's how they know where to prioritize interventions. So how do we address this seemingly opposing views about the clinician needing to just kind of get his job done and the setting that needs to have the discrete data? So one thing worth noting is that there's structure in all clinical documents. And what you're seeing here, I didn't want to let you down without showing you a little snippet of XML. I knew you'd be disappointed. Right? So this is a little snippet of a CDA document. CDA is an HL7 standard. It's an XML representation of clinical documents, history and physicals, discharge summaries. CDA is the standard that's cited under meaningful use. And basically, the way that CDA structures clinical documents is allows you to put in narrative, but it also allows you to add structure to the narrative where you can. Okay, so you always have the narrative in the CDA document, and you can also add some structure to it. And what the natural language processing and the big data analytic people tell us is, you know what, I would take some structure over no structure. The more structure you can put into the clinical documents, the better for us. So there's structure in all clinical documents, and I would argue that incrementalism has proven itself successful on the internet. Back when I was working at Kaiser, we were developing a national clinical library, and there were two camps. There was one camp that said, gosh, before you put any piece of knowledge into our clinical library, you have to apply these 25 metadata tags. And by the way, make sure that they've been highly QA'd and make sure they've gone through their review and populate the repository with these pieces of information. The other camp said, you know what? Throw everything you possibly can into the clinical library, and you know what? We'll spider it. And incrementally, not only will you get better at structuring the content that you're submitting, but we'll get better at being able to process the data that you submitted. So you can imagine which camp won at Kaiser. It was the camp that said, just send us everything you've got. When we did an experiment, we wound up with 2 orders of magnitude more data from that camp. And I would say that's a similar approach that Google took for the internet. Google didn't say, we're only going to index those documents that are submitted to us with these 25 different metadata fields. They said, gosh, give us everything you possibly can. And while you're incrementally structuring the kind of content that you're throwing at us, we're also in parallel going to be incrementally enhancing our big data analytic capabilities so we can leverage the information that's being given us. Incrementalism can work the same way for healthcare. And incrementalism can work the same way for healthcare in a way that kind of aligns with this notion of a big data strategy. And so I show this slide again, partly just because I think it's kind of a cool slide, but it illustrates the strategy for what I would call the big data incrementally structured strategy that we're pushing through HL7, that we're pushing forward in meaningful use, which is just let's focus on getting large volumes of data flowing early on. We don't need to wait until we can precisely communicate 200 data elements. Yes, we want 200 data elements, but we don't need to delay doing everything while we're focusing on that, because with just a little bit of energy, we can have hundreds of millions of clinical documents flowing in the United States that meets the needs of the frontline clinician, but it also then provides fuel to the big data analytic engines that are out there that have the capabilities, that know how to leverage that. So our strategy then is get large volumes of data flowing through minimally structured CDA documents, and then incrementally add more structure into these documents using what we call templates. And that we believe that this is, if where you want to be is having these 200 data elements, our contention is that the most effective way to get you there, if you will, is by leveraging our investment in clinical documents and incrementally adding structure to those documents rather than ignoring the clinical documents altogether and focusing solely on the structured data. I could ask if people agree or disagree, but maybe over lunch that'll be a topic. Because I think the biggest challenge that people have, and I still honestly have to scratch my head over this, is you're telling me, I want 200 discrete data elements, and you're telling me that therefore I should focus on moving narrative documents? Doesn't make any sense. I want data elements. Why am I sending these documents? And what we're finding, and what the big data movement is continually showing us, and what Google has shown us for the internet, is if we want those data elements, the best way actually to go after those data elements is to begin by just moving large volumes of data at a relatively low cost, I might add. The Consolidated CDA standard is the one that was cited under Meaningful Use Stage 2. So you'll start to see, as you're looking at clinical documents and leveraging clinical documents, what you'll start to see flowing in the US are consult notes, diagnostic imaging reports, these types of documents in a HL7 CDA format. Okay? So I guess just to recap, how does Consolidated CDA lead to meaningful use? I've probably now said it enough times where I hope we have some good debates about this strategy over lunch. Is it really the case? Is it really the case that if we focus some energy on moving narrative documents today, that's really going to be the most effective way to get us to a data-driven healthcare environment? Because I think really that's the fundamental area where people scratch their head and they say, is that really going to work for us? So what we're saying here is, yes, we believe that this big data incrementally structured approach is the best way to drive us towards a more data-driven healthcare environment, because it delivers common clinical documents to the point of care. So you meet the needs of the frontline clinicians right off the bat. It turns out in HL7 that the process of standardization, of creating standards, data standards, is time consuming. You have a lot of stakeholders that come to the table, so it can be quite time consuming. And if we tried to standardize everything within a clinical document, it might take us several years, not to mention it would then take several years for any vendor to implement those systems. So it's pretty easy for us to standardize clinical documents just at the level of sections. So here's the 9 different types of documents that we want flowing, and within those documents, here's the sections that we want to standardize. We can get agreement at that level pretty easily. I mean, every hospital I've ever worked in, you go into the dictation room and there's the little piece of paper stuck up on the wall of the cubicle saying, when you dictate this type of document, make sure you include these types of sections. So there's more commonality than there are differences in these common clinical documents across the US. And all we've really done is kind of locked that in through the standard. And even at that level of structure, it turns out that we've seen dramatic improvements in performance in big data analytics and natural language processing engines, because now at least they know what section of the document they're in. They know how to apply certain types of context. Incrementally adding key data elements into narrative is attractive to clinicians. It aligns with existing clinical workflow. We're not asking clinicians to automatically change and adopt a new workflow. We're not asking clinicians to continue to create your notes, but now as an afterthought, you also have to interact with this data entry form. And it turns out that this partial structuring facilitates natural language processing and other types of big data analytics. So the pathway to meaningful use that we're pushing for is hit the ground running with basic CDA to meet the needs of the frontline clinicians and also to support the needs of the big data analytic engines, and then incrementally layer in discrete data elements into CDA documents. So that's all kind of fun. I'm going to change topics a little bit now to describe how we demonstrated this notion at the National HIMSS meeting that, earlier this year. So at HIMSS, at the National HIMSS meeting, I think most people here are HIMSS members, at least Southern California HIMSS members, and probably a lot of you are quite familiar with the big national HIMSS meetings. How many people were there this year? Like, I don't know, a gazillion, right? About 30,000? More? 35,000? So it's big. It's a boatload of fun. Every year at HIMSS, we put on something called an Interoperability Showcase. The Interoperability Showcase, which has grown from this big to this big to this big, now it gets a whole room to itself. Within the showcase, within the Interoperability Showcase, there's different groups of people will get together to demonstrate interoperability for certain use cases. At the 2013 showcase, we worked closely with a group called Health Story. Health Story is one of the sub-organizations. It's a group sponsored by HIMSS. And what we demonstrated there was new approaches for coordinating long-term and cancer care. And so the scenario that we were demonstrating here was, imagine you have a patient with cancer, and that patient is seen by the primary care clinician, and then that patient is seen by the specialist, and then that patient may have to go see a radiation oncologist or a surgical oncologist. And you know, I know I was a primary care clinician, and I would see the patient back after the patient had been seen by the oncologist. And I can tell you from my perspective, I don't care how many discrete data elements you give me, I always want to see the oncologist's last progress note. So what we tried to demonstrate here at the HIMSS Showcase was, how can we leverage the meaningful use standards? How can we capitalize on this big data incrementally structured approach? And can we really demonstrate the fact that with this strategy, we can provide novel ways for coordinating the care of patients as they go from their provider to the specialist, maybe to the nursing home. We worked with the Health Story project, which is now sponsored by HIMSS. Health Story initially started off really as a group of transcriptionists that were like, wait a minute, everyone's talking about EHRs and you're going to leave us out. And that's crazy because we believe we have a very important role. We're responsible for 60% of the content in these documents. And by the way, you know, we know actually how to use narrative documents, and we're the most innovative when it comes to natural language processing, when it comes to big data analytics. So the Health Story Consortium was founded back in 2007. A very close working relationship with HL7. In fact, the Health Story project helped us define which types of documents should be included in Consolidated CDA, and they helped us then sponsor the development of those implementation guides. So if you've never been to HIMSS, where there's whatever 35,000 people walking around, and if you've never been in to see the Interoperability Showcase, boy, it's really a sight. It's really a sight to see. So the way that the Interoperability Showcase works is that this was our pod here. Other pods exist. And in each one of these pods, there's different use cases that those vendors are attempting to demonstrate. Our pod was here. You can just kind of sort of barely read it. This is the health story approach for coordinating long-term and cancer care. And so there was a group of, I think, 6 vendors that wanted to kind of demonstrate, and each one of the vendors plays a different role in the scenario. So here at the Interoperability Showcase, our goal was to illustrate how the meaningful use standards and how this big data incrementally structured approach would meet the needs of a patient with cancer being seen by multiple different providers in multiple different settings. And how do you just keep track of this poor patient and continue to provide patient-centered care? So we wanted to demonstrate the role of the standards. Here's a little bit more about the scenario that we were demonstrating, where the patient visits the primary care provider to review the mammogram. There's something wrong with the mammogram, so the patient then has to go see a surgeon. A biopsy is performed. It confirms that there's a breast cancer. The patient then sees an oncologist and then has to see a surgeon. A mastectomy is performed. The tumor board gets involved. The patient ultimately has to spend some time in a nursing home and then has to go home and be seen by a home health care nurse. And the point we were trying to make here was if you look at this type of scenario from a discrete data approach, what's really tricky is that I don't care how many discrete data elements we define, that's not necessarily going to give you what you need from a patient-centered care perspective. Sure, those data elements are going to allow you to do some innovative things with decision support and with quality reporting, and that's great. So there's no question that we want the discrete data elements. But the question is, if we focus on discrete data for the sake of discrete data, is that sufficient to meet the needs of, this is not an atypical scenario. This is not an atypical patient where this patient is seen, in multiple care settings. So in this particular scenario, not only did we demonstrate that the narrative document could flow, but meanwhile, we leveraged natural language processing technology and big data analytic technology so that we could, not only could we make sure that the primary care provider had the documentation that they needed, but also that the discrete data elements were there to demonstrate that the quality had been performed, or so that whatever decision support rules could be triggered. I think I talked very fast. So anyhow, that's it. Thank you very much.
So thank you so much. We want to take some time for questions, so don't everybody run off to lunch yet. So do we have any questions?
I would especially be interested in questions for people that disagree with the strategy.
The methodology of incrementally structured.
Started.
The debate. We'll have to have a for and against.
Right.
And
you were too persuasive.
I could live with that.
go ahead.
Yeah. I'm not going to vote whether I agree or disagree.
Okay.
I wanted to ask you just to explain one part of the strategy, which as you get the data flowing and you get more and more of the text-based CDA with minimal structure, are you suggesting that, kind of like with Google and so on, that basically after the fact, if we get really good at pattern recognition and other kinds of algorithms, we can sort of go back and after the fact structure the data? Or are you thinking that as we get better at what we understand we need and what we have available to us, we'll start adding more structure to subsequent documents? I'm thinking, when you use the Google analogy, that there is some backwards engineering that sort of can be done after the fact. And I just kind of was curious of what you were thinking.
So my answer is yes and yes. What's really interesting is when you talk about big data incrementally structured, the incrementalism is occurring in at least 3 different places. Number one, we're incrementally improving the standard so that the ability to send structured content goes up. But meanwhile, all of the brilliant people out there that understand the Google approach to parsing the information and parsing the narrative and doing something innovative with it, their techniques continue to evolve as well. So you might have all this library of clinical documents. Today, you're going to try to ask it certain questions, but without changing your raw data, tomorrow you might be able to do more with this data than you can do today, because there's also incrementalism going on the receiving side. The other place where there's incrementalism going in is on the user interface design. How do you capture these documents? Do you simply dictate them, or do you dictate them into a computer where the computer in real time is actually checking to see if you've captured some of the data elements that you're looking for? So I see incrementalism taking place in at least 3 different places.
I think there's, sorry, Sharif Tarman from Chalk. And anyway, so I think there's 2 issues that kind of come up, and I agree in that you do need to get away from having structured data initially and then do incrementally structured data. But part of the problem is that, as we kind of talked about, there's a burden for documentation. I think concepts such as documentation by, my normal workflow. So it's I do my normal workflow, and then the documentation sort of comes as a byproduct of what I'm normally doing to treat patients is an important concept. And I think as we reduce the burden on the physicians to document, you'll actually see better quality improvement. So I think all of us have kind of seen, we implement EMR, and then the quality of the documentation takes a hit. And there's a lot of, and this is attested when I was a med student in the VA, copying and pasting of huge amounts of data, and then there's nothing new that gets added. So the consultant's copying the internal medicine HMP and the plans there too, and then they're just adding on top of it. And so you get this redundancy of data. So I think these are things that are just concepts to think about. And so when we kind of get to that discrete element point too, and we look at Google, for example, there's been actually a lot of backlash to some of the Google, Facebook type presentation of data, because what happens is we try and bring that data forward, right? There's some inherent bias in it. So if you were Googling Egypt during the revolution and you didn't care about politics, you would probably just get all of the data for, come visit the pyramids and the tourism stuff. But if you're highly engaged in what was happening in the world, you would see a different set of information. So I think we have to be a little bit careful. Yeah. Comments? That's not a question. That's just me rambling.
No, I mean, if I were to kind of recast what you said in a nutshell, I'd say garbage in, garbage out. And especially, don't look at a clinical document for evidence of normal clinical findings, because really, if it says normal, it means nobody actually looked. Right? It was just pasted over there from some prior note. Now, let me see if I want to digress into this a little bit. I actually believe that the strategy here will have a beneficial impact at the point of data capture. I believe that the data capture burden is real, and one of the challenges, among others, now this is maybe a little bit digressing from the big data incrementally structured approach, but one of the problems faced by clinicians with the data capture burden is, well, everyone's just throwing their own data elements at the clinician. So the decision support community kind of says, here's the data elements we need. Meanwhile, the clinical practice guideline says it in a slightly different way. Then the quality measure comes along, and wait a minute, those data elements aren't quite the same here. So the approach we're taking, at least one of the approaches we're taking in HL7 to try to mitigate some of the data capture burden, is reach out to all of the federal stakeholders and make sure that there's alignment between the data elements that you need for quality reporting need to be the same as the data elements that you need for decision support, need to be the same as the data elements that a clinician just receiving a patient wants, because it doesn't make any sense to say, wait a minute, here's the data that I normally think I need to take care of patients, but you're telling me that that's not the same as the data elements that you need for quality reporting. So convergence of the data elements is also a strategy that we're taking to try to mitigate some of the data capture challenge.
We have time for maybe one more question, and then Dr. Dolin will be available during the lunch break, right? For any further
Sure.
discussion, debate, arm wrestling.
Arm wrestling.
I think we have a new political party, the Incrementalists. Any other questions?
Really, that's great if I was able to pull that
Yeah.
off.
That and clinical transformationists.
Yeah.
Any other questions? Yes, sir.
I'm intrigued by how you suggest incrementally improving your data. A thought stands out, though, and I think I'm leaning towards the direction you're going in, but a thought stands out. What happens to the decisions you've made on the data that you've used in the past that, you hadn't improved upon?
Uh-huh.
So is there an impact there that you've made decisions, you've made changes based on data that hasn't been fully flushed out yet?
Well,
Or you have inadequate data, maybe?
yeah. I guess I don't know if there's a well-studied response to that, but my response is, clinicians are constantly making decisions based on the best data that they happen to have at the minute. And if you've made a decision and a week later you realize that your data was wrong or that there's more data, sometimes you just have to shift your decision. And I don't know that this changes that at all. Our goal is give you the data so that you have it at your fingertips as you're making decisions. That's not to say that the data won't continually improve over time.
Okay, thanks.
Okay, we're going to go ahead and break for a lunch service. Thank you very much.